Now, neuromuscular blockers, they are crucial to practice for anesthesia and they facilitate endotracheal intubation. You have to remember this. And they will provide muscle relaxation, which is needed for surgery. Agents are cisatracurium, mevacurium, pancuronium, rocuronium, succinylcholine, and vicuronium. Now, sugammadex. This is a selective relaxant binding agent that terminates action of both rocuronium and virocuronium. It is 3D structure that traps neuromuscular block in 1:1 ratio and terminate its action. It is water soluble and it is eliminated via kidneys. Now, local anesthetics. What do local anesthetics do? They block nerve conduction of sensory impulses in higher concentration, block motor impulses from periphery to the CNS. Sodium ion channels are blocked to prevent transient increase in permeability of the nerve membrane to sodium that is required for action potential. This, when the propagation of action potential is prevented, sensation will not be transmitted to the source of stimulation of the brain. Delivery technique are topical, infiltration, perineural, neuroaxial, that is spinal, epidural, caudal. Small unmyelinated nerve fibers for pain, temperature, and autonomic activity are most sensitive. Structurally, these are all lipophilic group, amide or ester linkage to carbon chain, which in turn is joined to hydrophilic group. The most widely used are bupivacaine, lidocaine, mepivacaine, and ropivacaine, tetracaine. You can see here the mechanism of action. This is the drug and has membrane diffusion, and these are the sodium ion channels. This is the chemistry. This is the ester linkage and this is the amide linkage, and the carbon chain is here for local anesthetics. Now, local anesthetics cause vasodilation. Rapid diffusion is away from site of action and short duration. These drugs are administered alone. By adding epinephrine, the rate of local anesthetic absorption and diffusion is decreased, and also minimizes the systemic toxicity, increases the duration of action. Hepatic function will not affect here. Onset, potency, and duration of action. Onset is influenced by pH, morphology, concentration, pK, and all of these factors. Metabolism is through liver. Prilocaine, a dental anesthetic, is also metabolized by plasma and kidney. Allergic reaction. Patient report allergic reaction, and the common side actually are due to the co-administration of epinephrine. Allergy to one ester rules out the use of another ester because the allergic component is the metabolite para-aminobenzoic acid, and which is produced by all esters. Now, you can see here characteristics of local anesthetics that are PABA. They are para-aminobenzoic acid. Characteristic: metabolism: benzocaine, chloroprocaine, cocaine, procaine, tetracaine. Rapid by plasma cholinesterase. Less likely for systemic toxicity. Allergic reaction is due to PABA derivative form. Stability in solution: breaks down in impulses, heat or sun. Ampules, it will break down if it is subjected to heat or sun. Onset of action is slow. pKa is higher than the physiologic pH. These were the esters. Now, amides: bupivacaine, lidocaine, mepivacaine, prilocaine, and ropivacaine. Metabolism is slow. Systemic is more likely. Allergic reaction is rare. Stability is very stable. Onset of action is moderate to fast, close to physiologic pH. Now, drug: bupivacaine, which is an amide, chloroprocaine, which is an ester, lidocaine, amide, mepivacaine, amide. Procaine is ester. Ropivacaine is amide, and tetracaine is also ester. Now you can see high potency, slow onset and long duration. For this is low potency, rapid onset and short duration. Lidocaine, low potency, rapid onset, intermediate duration. Mepivacaine, low potency, moderate onset and intermediate duration. Procaine, low potency, rapid onset, short duration. Ropivacaine, high potency, moderate onset and long duration. Tetracaine, high potency, slow onset and long duration of action.